Now, last but certainly not least, and I'm not biased at all, but very warm welcome to our very own Edmond Rafie from the CHUM.
So hello, everyone. I want to take a moment to thank the organizers to invite me to give a slightly less fundamental talk about the real-world analysis of neoadjuvant chemo-IO in resectable non-small cell lung cancer, the Montreal experience. I have no disclosures. So the objective of our study was to look at the applicability of neoadjuvant chemo-IO regimens in a real-world setting. So we conducted a retrospective analysis of prospectively maintained databases from 2 high-volume thoracic surgery centers in Montreal, so the CHUM and the MUHC, so very much in the spirit of Elixir. And we did this in order to see, out of the clean, sterilized, controlled world of clinical trials, if the data holds up, and perhaps more importantly, if we can learn something new from this data. So for patient selection, we included all patients with proven clinical stage 2 to 3 non-small cell lung cancer who had received at least 1 cycle of neoadjuvant chemo-IO between April 2019 and August 2024. We excluded patients with CN3 disease, patients who had any other form of neoadjuvant treatment other than chemo-IO, and we excluded patients who had EGFR, ALK, ROS driver mutations as well. Now, looking at our N cohort, we ended up with 78 patients. The median age was 66. Median follow-up time was 12.3 months. We had more patients who had stage 3, according to the AJCC 8th edition, and most of them were 3A, but 6 of them were 3B. We had an equivalent distribution of nodal involvement through N0, N1, and N2. We had a higher propensity of patients with adenocarcinoma and PD-L1 high, and as CheckMate 816 as of now is the most accessible regimen, most of our patients had a combination nivolumab with platinum doublet chemotherapy. So now looking at the portion of neoadjuvant treatment, we reported a 19% of grade 1 adverse events, 25.6 grade 2, and 14% grade 3, and most importantly, no grade 4 or grade 5 adverse events. And it's important to note that 94% of our patients completed their full course of neoadjuvant treatment. Now, looking at the surgery portion of the treatment, 95% of patients underwent surgery, so 4 out of 78 did not. The reasons for not proceeding to surgery was one patient who had a disease that was too extensive, another patient had a pancreas tumor treated with CRT, another patient was too frail, and unfortunately the last one progressed to the pleura. Now, looking at actual surgery characteristics, the median time between the last dose of chemo-IO and surgery was approximately 6 weeks. 86% of patients had minimally invasive interventions with an average operative time of 180 minutes, and the median post-operative length of stay was 3 days. Now, looking at margins, we were happy to report that 94% of patients had R0 margins. And now looking at adverse events, we had 3 patients with grade 3 adverse events, 1 patient with grade 4 adverse event, and unfortunately 2 patients who passed away 30 days during the 30-day period after the surgery. Interesting to note that both of them had pneumonectomy, and that the treating physicians did not find any link between the neoadjuvant treatment portion and the mortality. Now, looking at the results, we were happy to report that our PCR rate was the same as the one that was reported in CheckMate 816. So we found 24% PCR, 33% MPR, and as expected for PCR patients, there was a higher propensity of patients with PD-L1 high. So 67% of our patients having achieved PCR were PD-L1 high. Now, looking at survival, although the data is very immature, we only have a median follow-up of 12.3 months. We can see a clear trend for both PFS and OS regarding PCR status. So on the left, we have PFS rate of PCR that's 84 versus 77 in non-PCR, and for OS, we had 95% at 1 year versus 77%. And finally, we performed an exploratory analysis in order to identify any predictive or surrogate biomarkers, and we found that 70% reduction on FDG PET was associated with a pathological CR. So this was done on a cohort of 39 of the patients that had PET scan at baseline and right after the end of neoadjuvant treatment prior to surgery. And we determined this optimal cutoff using Udin's J statistic of 70%, which yielded an AUC of 0.89, a sensitivity of 92.3, and a specificity of 73.3. And we performed a multivariable analysis that showed that SUV decrease of more than 70% favored PCR in a statistical significant way with a hazard ratio of 30.1. And then on the right, we tried to compare and see if more classical, traditional ways of characterizing a tumor, so RECIST, held up the same predictive power, and unfortunately it didn't. So we can see here that some patients who were deemed to have partial response in fact had PCR, and conversely some patients who were deemed to have stable disease ended up having PCR as well, suggesting that potentially this biomarker could help in de-escalation and maybe one day omission of surgery. So key takeaways, the study confirms clinical results from phase 3 trials and further supports the role of neoadjuvant chemo-IO in patients with resectable non-small cell lung cancer. Our rate of neoadjuvant adverse events was consistent and even better than the literature had reported. 95% of patients proceeded to surgical resection with a majority undergoing minimally invasive intervention. The overall PCR rate was 24%, with a trend suggesting an advantage for PD-L1 high patients. And finally, PET scan data may serve as a surrogate biomarker of PCR, with 70% reduction associated with PCR. I want to take a moment to thank the first authors of this project, so Joseph Sittlinger, Olivier Salco, Luciano Maqueda, Andrew Meng, and Maxime Tétu. I want to thank everyone who participated to this study, my dear mentors, Dr. El Krief and Dr. Routy, and the organizers. It's truly such an honor to be here.
Dr. Blais has a question on his data.
I didn't see this data before, so that's amazing. Is PET response a better predictor of OS than .CR?
That's a good question. Unfortunately, we did not look at that, but we will look at that for the paper.
But maybe that's a good question. You know, the role of PET scan before surgery, is it a new standard in our institution? With Moish and Jonathan, we have a trial to address that. But I know in the guidelines, CT is sufficient, but that will be important to follow.
Thanks for an excellent presentation, and congratulations to the Montreal group on your extensive experience. An observation and a question. Was I correct in seeing that you started with 240 some patients and then you end with a cohort of 78? Is that correct? So my impression of this is that you are presenting real world data, but in some respects you then make it emulate the trial, inclusion criteria. And I believe that many of these patients were on trial, I'm guessing, no, these are all post-trial patients?
Yeah, exactly. So they had to respect the indication.
Okay. One thing that I would find interesting, though, because I think a lot of people, we've talked a lot in this room about doing things that are coloring perhaps a little outside the line, but based on tumor biology. And I get the impression that there's probably quite a few patients here who, who had some form of treatment that wasn't perhaps exactly like their trial. Would you consider including some of those patients as a sort of a side description when it comes to publication to show what is the real life application where they don't necessarily fit trial criteria?
Yeah, I think that would be pertinent to look at that. But our objective was really to see for the actual indication of the treatment, how did our patients respond, and if the data held up to what we've seen in Checkmate 816.
Dr. Malowski?
How did you decide on 70%?
So we used
50, 60, 70, 80?
Sorry?
Did you look at 50, 60, 70, 80?
Yeah, so Udin's J statistic enables us to calculate the optimal cutoff for the highest AUC. So that's how we determined it.
Okay, and so when you talk about an SUV, clearance of 70%, you took the very first PET scan and you're comparing it to that?
Sorry, can you just repeat the question?
You must have had 2 PET scans.
Yeah, exactly. So one at baseline and one after neoadjuvant treatment before surgery.
And if you get a 70% reduction, is that total volume or is that just the SUV number?
Just the SUV.
Just the SUV.
Yeah. So we looked at anatomical categorizations and they didn't hold up.
I think this is really important because now that we have, Keynote 671, maybe we should be giving those people 4 cycles, not 3. Like if you thought that maybe if you see that, you would give another sort of round of chemo.
Yeah, definitely. I think the 70% cutoff should be tested in further trials.
Yeah, and just to add to that, I mean, not so much a question, but just a thought that this is really great because it's information that gives some predictive information or at least prognostic information before you actually have to cut into the patient. So if trial designs could be done where you give their first 3 cycles and then go on to surgery for those that get their 70% reduction, but give some sort of escalation of treatment to those who do not, and then go on to their surgery and see what effective therapies can then, achieve a 70% PET reduction before surgery. It's a very powerful surrogate.
Absolutely. The more data, the better. And ideally, they would also have microbiome analysis and all of that.
Thank you. So I'm just wanting to ask, as per the timing of your post-treatment PET, from our own experiences, that sometimes the PET may be not quite negative, and by the time of surgery, it was actually mostly necrotic. So there's still some cells that are dying. So if you do it kind of randomly at different times, you may have different results in terms of your ROC curve.
That would be a very interesting analysis to do as well. Thank you for your comment.
Excellent. So thank you very much.